Hi everyone, I'm Dr. Stevens, Eric Stevens. I'm an endocrinologist with Hoag Medical Group and I practice at the Hoag Huntington Harbor location.
Hi, my name is David Ahn. I'm an adult endocrinologist. I'm the program director at the Marion Dick-Allen Diabetes Center at Hoag Hospital in Newport Beach.
All right, so we're going to talk about using technology to lead a successful life with diabetes. So we can start the presentation. Okay, so I'm just going to go over not so much tech stuff a little bit later, but just getting a bigger picture of diabetes. So overall, the goals for sugar control, we kind of use the A1C as kind of our gold standard. And so less than 7% is what we're looking for in terms of controlling your sugars if you're young, newly diagnosed, and you have no other major complications. And then if you're older, maybe like over 65, or have had diabetes a long time or have other multiple medical conditions, our goal is to keep your A1C under 8%. And so when you're checking your sugars at home, we're looking for fasting sugars around 80 to 130. And then if you check either before meals or 2 hours after meals, we're looking for a range there. So that's kind of how you can keep track about what your sugars are doing. And so to give you another estimation, an A1C of 7% is around average sugar of 150, 154. If you checked your sugar every minute of every day for 3 months and sort of averaged it out. And then an A1C of 8% is around 180. Okay, next slide. So now that we know what our targets are, how do we help achieve those? Diet is really important. So there isn't one diabetic diet that fits everyone's needs. So everyone asks, like, well, what should I do? Well, it just depends what you yourself can adhere to the most. And so kind of a mainstay would just be having a low-carb diet overall. There's not really a certain amount of grams of carb per day, although I usually say maybe under 100, 150 per day is some kind of target to achieve. But in general, you just want to lower carbs, and then you also want to increase protein and vegetables, so that's how you'll substitute some of the calories that you're losing from reducing the carbs. And so things like potatoes, pasta, bread, those are all carbs that you want to reduce. Portion control is really important, so you can still have carbs, but you want to limit the amount that you're having, and so that's really key, not to make yourself too crazy and just cut out all the carbs. Other things to note, so people talk about whole grains versus like white bread, for example, is kind of the classic example. You want lower glycemic index, so basically things that have more grains in them because the sugar won't spike as quickly after those foods. So you want to prioritize those types of carbohydrates if you're going to have them. And then an important thing is people, when they go out to eat, the restaurant doesn't really care if you have diabetes or not. They just want the food to taste good. So, avoid eating out frequently because it'll usually be high carb and high fat, which is not so great. Okay, and then so this has a little bit to do with technology in the sense of there's a lot of new medications in the last 10, 15, 20 years out for diabetes. And so metformin is usually the first line medication for type 2 diabetes. So we usually start with that as our foundation. If you have type 1, then none of this slide except for the very bottom, which we talked about insulin, will apply to you. So the rest of these are for type 2 diabetics. And so there isn't really a good guideline of all these other categories for what to choose next. But the newest categories are the GLP-1s and the SGLT2 inhibitors. And if you have heart disease, for example, the SGLT2 inhibitors might be something to consider because they have been shown to reduce major adverse cardiovascular events in addition to lowering A1C. And then the GLP-1s also, if you're looking to lose a lot of weight, these can also help you lose weight. And then insulin, we kind of, in type 2 diabetics, we kind of use towards the end in terms of if you can't get control with these other non-insulin medications, we'll move on to insulin. Okay. And then real quickly about insulin. So These can only be used, so if you're type 1, you can only use insulin. There's a lot of different long-acting insulins now. They're all kind of roughly the same. There's a little bit of nuance to each of them, but you give it about either once or twice a day, depending on which one. And then you also will include short-acting insulins if you need better control for your meals, like Novolog or Humalog or Apidra. And you would give that before each meal. And so it stops the sugar from rising before each meal. And so if you do the math, if you eat 3 meals a day, you'd give 3 injections of the short-acting and 1 injection of the long-acting. So it's usually around 4 injections per day. And so these are overall newer insulins in the whole system, as opposed to some of the older ones, which you still may see, like NPH or regular insulin, which we use a little less frequently, but sometimes cost can be prohibitive for the other ones. Okay, and then so talking a little bit more about glucometers. So people ask me, like, what is the best glucometer, most accurate? Well, they have to get approved by the FDA. So there's not really one that's more accurate. It's just kind of often dictated by what your insurance company wants to cover. And I wouldn't say there's any particular brand that's better than the other. You just want to make sure to get the most accurate results to clean and dry your hands. Try and use new strips. Don't go digging for old ones that you've had for a long time, because it may give you a less accurate result. So that's what I would say about the glucometers. Okay, more tech stuff. So diabetes apps. So these are just a couple that I've known about and like. So My Sugar and Glucose Buddy. So these are just ways to make you a little bit more organized, because diabetes is a lot about generating data, following that data to try and achieve our sort of numerical targets. And so these apps kind of compile all that together and make you more organized. So they'll include food, medications, what your weight's been. If you're doing insulin injections, you can go through those as well and put that in there, and then you can kind of keep track of it, bring it into the doctor's office, and we can look at it together. And it kind of helps motivate people. So diabetes is a big part of it, is motivation to try to keep on top of your sugars, and so these can help you stay organized in that way. And then, so now we're going to talk more fully about diabetes tech. So just to segue in for Dr. Ahn. So the major things in terms of technology are continuous glucose monitors, so you don't have to check your finger sticks as much anymore. Using insulin pumps, primarily for type 1, but also type 2 diabetics. Pens, so like insulin pens that have ways that you can keep track of what you're injecting. And then we talked a little bit about diabetes apps and software. Okay, so I'll hand it over to Dr. Ahn.
Great, thank you, Dr. Stevens. So I'd like to talk a little bit more in depth about some of those things that Dr. Stevens just highlighted on his last slide. And I really am excited to share with you about something called continuous glucose monitoring, or CGM for short. It's something that has gone into the mainstream consciousness. There's a lot of marketing campaigns. You might have seen commercials or have friends that are using one. But it's really fascinating if you haven't heard about it. And one of the main reasons why it's so exciting is that it can be a replacement for having to do painful finger sticks. So that's one of the things that my patients dread the most. So not having to do those finger sticks can be a huge benefit to our patients. But not only that, it actually provides a lot more data. So most of these sensors or CGMs will actually sample your blood sugar every 1 to 5 minutes. So that's going to be about the equivalent of 300 checks, or up to 1,500 checks a day. So even my most diligent patients, maybe they're checking 6 times a day with the finger stick machine, 8 times a day, if they're very, very on top of it. But a CGM just blows that away in terms of the number of data points you're getting each day. And lastly, it really is a great way to learn your body. You don't have to be super advanced in your knowledge of diabetes to be able to look at the dots on your screen and see when it goes up, you realize there might be improvement you can do. And when you eat healthy, exercise more, you can see that the curve is a lot more flat. And so it's just a great way to see and learn from your body in real time. And I guess one thing I didn't highlight is that it is a wearable sensor, so it's often like a disc or like a patch-like sticker that you put on your abdomen or upper arm. And it communicates to a physical reader or smartphone. And I'll show you a few examples on these next couple slides. So probably the most common type of CGM for the type 2 diabetes population is something called the Freestyle Libre. And this talk is pretty timely because the Libre 2, which is a newer version of it, just got released a couple months ago. And the benefit to this now is that it adds it definitely is more accurate than the original Libre 1. But the way that this device works is you have a sensor worn on the upper arm, that's what that gray circle is, and you use the reader or your smartphone to swipe over the sensor, and it can scan through your clothes, so you don't have to lift up your shirt or your sleeve, and it will give you a reading of what your sugar is. And it's very convenient because you don't have to do the finger stick. One of the new features that came with the Libre 2 is that it can now tell you if your blood sugar is going too high or too low without you having to scan the device. And so that's a new feature. So it will tell if you're going high or low, and then you're prompted to scan that sensor and learn what your number is. As you can see on the little screenshot, so every time you scan, you get a number, you get a direction arrow, and you get a graph that shows you the last 8 hours of your blood sugar. And it's that graph that really helps people learn, how their body's reacting to food, different types of food, and exercise. So for this Freestyle Libre 2, the sensor is worn for 14 days. It's very accurate and almost nearly as accurate as a glucose meter, but it's just slightly less accurate, but still very accurate. And if you have to pay cash, the full price would be about $80 to $120 a month. It may be cheaper with insurance. And while $80 to $120 a month is not pocket change, it is sometimes worthwhile because for people that are checking their blood sugars 4 times a day, the cost of those test strips alone might run you $80, $100. So it does become reasonable for certain populations. And that's obviously something every patient needs to decide for themselves. Now the next product is called the Dexcom G6. And this is a little bit more fully featured continuous glucose monitor. But it does come at a slightly higher or somewhat higher price point, which I tend to prescribe it more often in my patients with type 1 diabetes. But one big distinction between this product and the previous product is that the Dexcom G6 you don't have to swipe over your arm because the sensor actually goes wirelessly to a nearby smartphone. So you just look at your smartphone and you can see what your blood sugar is without having to do that swipe motion. Similarly, it does provide alerts for highs and lows, but an advantage over the previous product is that it does predict low blood sugar 30 minutes before it happens, so it can be a little bit more preventative in that way. Unlike the last product, which has a 14-day life on the sensor, the Dexcom G6 can be worn for 10 days. And an interesting feature with the Dexcom G6 is that you can actually have followers who can see what your blood sugar is in real time. So, for example, little children with type 1 diabetes, that follow feature really provides a lot of reassurance for their parents who might be sleeping in the other room and worry what their blood sugar is. But as I said, it is quite a bit more expensive. Without insurance, the ongoing cost would be about $400 per month. But hopefully insurance will bring that price down for those that need it. One thing I forgot to add is that these products, I'll get back to that in a future slide. But I did want to highlight the importance of using continuous glucose monitoring in that it does kind of change what we focus on when we're managing blood sugar. So Dr. Stevens did a fantastic job breaking down what we call the hemoglobin A1C, which is a blood test that many of you are probably familiar with, and that's been kind of the traditional model for looking at blood sugar control. But now, with these CGM devices, you have knowledge of what your blood sugar is every 5 minutes or every minute throughout the day. And these devices can report what we call time in range. And that shows the percent of time in the day that your blood sugar is at goal, which is defined as 70 to 180 in most of the patient population. So on this figure, there's a lot of numbers and a lot of colors. I would focus on the leftmost column because this is going to apply to most people. And basically, the recommendation is that people's time in range be above 70%. So my goal for my patients is to make sure their blood sugars are between 70 and 180, more than 70% of the time. And also, in addition to that, they want to spend their time less than 4% of the day low with the blood sugar less than 70. So if my patients are achieving both of those goals, I'm very pleased with how they're doing. Now the other two columns represent different age groups or different subsets. So the middle column is for older patients who might be at more risk of low blood sugar. And the third column on the right is for pregnancy and type 1 diabetes. But these are more nuanced discussions that we can focus on in another time. One thing I did want to highlight is that CGM can be expensive, as we discussed. Even the cheaper product is still, $80 to $120 a month. So there is an option that might be available for those of you who aren't willing to pay that price all the time. So there's something called professional CGM, which is basically a one-time wear where maybe your clinic or your endocrinologist can put on a sensor for a 2-week or a 10-day period, and you can use that 2-week or 10-day period to learn about your body, and your doctor can kind of look at the data over that period and come up with some recommendations for you. So it's kind of a one-off. It's generally pretty well covered by insurance, and it's also a great way for people to give CGM a try and see what insights they can learn about their body. And both of the products that I described earlier have professional versions that you can wear as a one-off, a one-time situation through your provider. One of the products, the Dexcom G6 Pro, can come in blinded or unblinded mode, which means in unblinded mode, you can actually see what your blood sugar is in real time. And there's also blinded mode where you kind of don't see your blood sugar in real time. And you kind of, I tell my patients it's almost like when on National Geographic when they put those tags on the animals and they run around and kind of be their own self. Sometimes we can put a blinded CGM on a patient where they're encouraged to kind of live their standard life and come back 2 weeks later, and then we review the data after that 2-week period. One thing I did want to highlight was another innovative category called smart insulin pens. So this is only for people that are requiring insulin, but with technological advances, there are now Bluetooth-enabled insulin pens that can actually transfer data to a nearby smartphone. The InPen by Companion Medical is one such example. It pairs to a smartphone. It can integrate data from a CGM like we just talked about. And one of the great things is it basically automatically keeps a nice diary of all the insulin doses that you've taken. So that when you go back to your doctor, he or she can see your blood sugars, he or she can see what doses of insulin you took, and make the appropriate recommendations. Also, it does have a dose calculator that you can configure with your endocrinologist so that you know how much to take for each meal. So that can be really convenient. The last thing I wanted to touch on when we discuss technology and your diabetes care is just the presence of telemedicine and virtual visits. It's something that I'm sure you've heard a lot about from both Hoag practices and just all over the country. But diabetes care really is ideally suited for virtual care. A lot of it comes down to what you're doing, right? So in the end, since so much of managing diabetes is what you do on a daily basis, these virtual sessions can almost be coaching sessions where your doctor or provider can give you insights and some tools to work on. And with the availability of all this data from continuous glucose monitors and glucometers, like Dr. Stevens shared, you can actually share that data with your provider without having to go to their office. Also, with diabetes care, there isn't a huge reliance on the physical exam, right? We're not cardiologists that need to listen to every murmur on your heart. So that also lends itself well to virtual visits. On the next slide, I kind of have a picture of us wearing these face masks because sometimes I think people they underestimate the value of virtual visits, especially in this day and age. Because a lot of times I'll have a patient that wants to come in face-to-face, but then they come in and it's, your doctor's wearing a mask, your caregiver might not be able to come into the room with you, you have to leave your child in the waiting room, everyone's socially distancing. So sometimes you can actually have a little bit more personal interaction via the camera in the sense that you can at least see our facial expressions and our mouths. And sometimes, especially for my hard of hearing patients, being able to read lips plays a really important role in their understanding. Also, with these virtual visits, I can share my screen with my patients, and so I can show them websites or resources to look at. And while I can do that when they're in my office, sometimes it's always kind of weird when I'm typing and my patient's looking over my shoulder at what I'm looking at. But on a virtual encounter, it's very easy to share the content without having to hover over my keyboard. So there are some unexpected advantages. But this next slide, though, does show that there are also unexpected challenges. So for example, while continuous glucose monitors, like I just shared, are really convenient for sharing data remotely, glucose meters don't generally behave as nicely. So this is an example that I screenshotted from a patient of mine where they had to hold up their glucose logbook on their papers, and I had to take screenshots to try to figure out what their blood sugars were doing. So sometimes it can be a challenge. So if you are going to choose to do a virtual visit, it's really important to make sure that you're preparing your data and maybe emailing it to your provider or faxing in some pictures to help make that visit go as smoothly as possible. So I think that's it for our prepared content. Let's check in.
We have some questions.
Cool.
So Jay would like to know, for someone with an A1C of 5.7, previously in the mid-6s, is continuous glucose monitoring necessary or recommended?
Yeah, I'll answer that, I guess, because I just talked about the continuous glucose monitoring. So that's a great question, and it really comes down to, I tell my patients it really comes down to them, because it comes down to I have patients that might be using a continuous glucose monitor to learn about their body. Sometimes being able to see that data every minute of every day helps them be held accountable. So some patients really like that, and interestingly enough, there's actually a lot of people are starting to experiment with wearing continuous glucose monitors in people without diabetes. So athletes, perhaps people trying to lose weight. I think over the next 5 to 10 years, more and more people will be wearing continuous glucose monitors. Maybe it'll be featured in the watch or something like that. So I don't think it's not I wouldn't say it's not helpful. It might be a little bit overkill, I guess, when it comes to monitoring, but if you can afford it, and it does help keep you accountable, why not use it? But at the same time, I have some patients who, it's kind of a burden. Maybe it's a burden on them financially, or maybe they don't kind of like that constant stream of data making them feel a little bit overwhelmed. And if I have a patient like that, who has an A1C of 5.7, which is pretty great, I would say, don't stress yourself out. So it's, an individualized answer, but I don't think it's a straight no or a straight yes.
Why do we want the blood sugar low for 4% of the day?
So the question was, why do we want the blood sugar low for 4% of the day? I guess Dr. Ahn could correct me, but this is just like kind of a minimum, so you don't necessarily want it to be less than 70 or less than 54 on that chart. It's basically just that those are kind of the maximum threshold. So if you're over like 4% of the time in the low range, then that's not so good. We might want to adjust your insulin or whatever you're on to make sure that you're not getting those lows so frequently. So the 4% is like a maximum threshold that we would want.
Right, 0% would be great, but up to 4% is acceptable, we'll say.
Anne would like to know, do you know if Medicare covers the continuous glucose monitors?
Yeah, so it's very complicated, as you might expect. So with Medicare, they have some pretty firm guidelines. So they only cover it officially with patients that are taking insulin shots 3 times a day or more and checking their blood sugar regularly. However, in light of COVID-19, the administration has kind of said that they're not going to enforce the guidelines. So it's a little bit open-ended. So technically, officially on paper, there are those minimum requirements of being on insulin 3 times a day. But like I said, we're kind of in this Wild West period during COVID-19 where it may be covered by your Medicare plan. But one thing I might add is that covered by Medicare can mean many different things. As many of you might know who have gone to the pharmacy and found out that your medication that's covered by Medicare is $400 or something like that. So even though when we say covered by Medicare, that doesn't necessarily mean it's free or even cheap, unfortunately.
Do the supplemental drugs such as Trulicity help? And if so, what about the expense?
Okay, so the question was, do the supplemental drugs like Trulicity help, and then what's the cost?
Yeah.
So yes, they do help. So if you're type 2, we're talking only about type 2, the Trulicity, Ozempic, the GLP-1 category is a pretty potent category in lowering A1C, so they're usually a pretty good choice. They tend to be more expensive, just like the other category, the SGLT2 category. Although sometimes it really, again, it goes back to your insurance. So sometimes I've had patients where it's a $5 or $25 copay, and then other people, they come back and it was like several hundred a month. So the answer is yes, they do work. They're definitely something that I think about a lot for most of my type 2 patients. But they may be more costly, and so you kind of have to balance how much benefit you're actually getting from it, like A1C reduction or weight loss, versus the cost. So.
And I think we can move on to the questions.
Yeah. So some questions we have written down is, I guess we'll kind of both take turns answering it. What common misconceptions or myths about diabetes do you come across and have to dispel with your patients?
Common misconceptions. So common misconceptions are basically the inheritance, actually, of type 1 and type 2. So actually a lot of people think type 1 because I guess it's a little bit more rare, is genetically inherited, which is true, but actually there's a stronger link for type 2. And kind of go back to this study on like identical twins, where the family history of type 2 is a more potent contributor to if you're going to develop type 2 versus type 1. So I think a lot of people think that they could get confused about genetic inheritance. And then another one I would say is people sometimes just feel like if type 2 is just because of your diet. So it's not. So there's a lot of obese people that don't necessarily have type 2 diabetes. And just because you eat healthier or better, if you have type 2 diabetes, doesn't necessarily mean it's just going to go away completely. It'll definitely help, but there's other factors like ethnicity, your age, genetic family history that contribute to developing type 2. So there's a large portion that's within your control, but there's also a portion that's not. So yeah.
Yeah, I think for me, one is kind of like, I notice a lot of my patients are hesitant to start medication because they feel like they'll have to be on it forever if they start. And that is definitely not the case. I will admit a lot of times doctors were not as good about taking off medications when they're no longer necessary. But there's nothing about diabetes medications that build dependence on them. I think we both subscribe to the theory that kind of less medications is better, but at the same time, if you do need a medication, it doesn't hurt to try, and it doesn't mean that you'll have to be stuck on it for the rest of your life. And kind of along those lines, I think there are a lot of misconceptions about insulin, and I think patients are very scared of insulin. But while we don't necessarily, I think we all tend to not use insulin as a first line or even second or third line agent. When it is recommended, it does play a role, and it's not the boogeyman. It can be a very effective and useful medication. Another question is, are there any books or resources you'd recommend for people to learn how to eat with diabetes?
Eat with diabetes. Yeah, so I guess I don't know any books in particular. You probably have to go see the nutritionist for that one. But a good overall resource is the ADA, so that one's kind of the big one, so the American Diabetes Association, so ada.org. If you go on there, there's all sorts of information about even pre-diabetes, diet, exercise, lifestyle. They make all sort of the standard of care guidelines and the guidelines that we follow and that I follow, Dr. On follows. So we get a lot of our information from them. And so I think in terms of learning to eat, that would be a good place to start.
Yeah, that's a great resource. And I think Dr. Stevens did a great job talking about, in his portion of the talk, about the various diets, and there's no one set diet. So I have a couple resources that lean in different directions. And the fascinating thing is that people can take very different dietary approaches and have similar success in controlling their blood sugar. And so to speak to that, for example, there's a book called Mastering Diabetes. And it actually is a whole food plant-based approach. So it's essentially a vegan approach to managing diabetes. And it can be very successful in my patients. So if you kind of lean that way, that's a great book to check out. Almost on the exact opposite end of the spectrum, there's a great website called dietdoctor.com, and that's all spelled out. So dietdoctor.com. And that's actually a resource that's very supportive of the ketogenic diet or low-carb diets, which tend to have a lot of meats and proteins. And I have a lot of patients that do really well there. So if you're kind of leaning more towards like a keto diet or an Atkins diet or a low-carb diet, that's a great resource for that. And there's also a great resource called the Diabetes Code by Jason Fung, who's a physician. And he also is kind of more of a supporter of low-carb dieting. And he also is a big believer in intermittent fasting and using diet as a way to reduce the need for medications. So those are some good resources. So you had mentioned a nutritionist. When should our patients, or when would you recommend that a patient see an endocrinologist like us, or see a diabetes educator or a dietitian?
So I would say for diabetes, so let's start with the diabetes educator. So anytime you have diabetes or are first diagnosed, or if you've had it before and you haven't gone, you should go see a diabetes educator. It's actually part of like overall standard of care that you at least have one visit with a diabetes educator or nutritionist, because as I had mentioned before, that diet and exercise and overall lifestyle, low-carb diet is really important in terms of controlling your sugars. So diabetes educator, probably can't see them enough until you feel like you're bored of seeing them. For endocrinologists, so usually the primary care doctor will manage kind of more easy to control diabetes. If you're type 1, I would say invariably you should see an endocrinologist, and probably the primary care doctor would refer you that way anyways. But if you're type 2 and maybe just on metformin and you're doing pretty well with your A1C under 7 and the 6s, the primary care doctor probably would feel comfortable managing that. And then when you start getting into the other medications like Trulicity that we had talked about earlier, they may feel a little bit less comfortable, and they might want to get a little bit more of our expertise. So I say once you get past metformin and definitely on insulin, then you should probably start seeing an endocrinologist.
Yeah, I think that was really well stated. At the same time, especially if you have a PPO insurance plan, it's also dependent on when you're interested in seeing an endocrinologist. So, it's an individualized discussion, but I think Dr. Stevens' guidelines were very reasonable. Okay, cool. So I think that is our time. Hopefully that was helpful. I'd strongly recommend that if you're interested in learning more, check out Dr. Stevens. He's in Huntington Beach with Hoag Medical Group. I'm at the Diabetes Center in Newport Beach with Hoag Hospital, and thank you very much for tuning in.
Thank you.